Today we're going to think about interstitial lung disease. Those are the lung diseases that affect the walls of the alveoli and the soft tissue around the bronchi. They can make the lungs really stiff and hard to inflate. Here are some key ideas about interstitial lung disease. It can either be acute or chronic. And in chronic interstitial lung disease, it's usually classified by its cause. The dust diseases, pneumoconioses, diseases with granulomas, diseases that are primarily just due to fibrosis and smoking-related diseases. Diffuse alveolar damage is the acute interstitial lung disease. It occurs due to severe acute pulmonary insults like shock, viral pneumonia, inhaled irritants, lots of water in the lung from near drowning, in surfactant deficiency, in newborn infants, in burns, in pancreatitis, anything that results in shock. Macroscopically, it appears as red, wet, heavy lungs. The key feature in diffuse alveolar damage histology is hyaline membranes. You can see them there, that pink line overlying the alveolar wall. But note how thick the alveolar wall is. It's full of edema. There's also type 2 alveolar cell proliferation and lots of myofibroblasts proliferating there. When they're mature, they will become fibroblasts and excrete collagen. So what we end up with is really thick fibrotic alveolar walls. Pneumoconioses are caused by inhalation of inorganic dusts, things like coal and silica and asbestos, so they're often seen in workplaces. Pneumoconioses cause damage because the dusts cause fibrosis. The amount of fibrosis is related to the length of exposure and also whether or not each individual patient responds in a brisk or really quite indolent way to the presence of these irritants. The pneumoconioses are named after the particles that injure the lung. Asbestosis, coal worker's lung, silicosis, which also can occur in coal workers but is due to silica rather than carbon accumulating, and hard metal pneumoconiosis, which occurs in metal workers. Asbestosis is the classic of these. Asbestos is a long, thin, fibrogenic material, which is hard to clear from the lungs. It acts as a tumour initiator and promoter. We can see it as asbestos bodies illustrated on the right here. The long, thin, clear asbestos fibre with the brown beads on it that are made of iron and protein mixed together. If you've watched the episode on lung cancer, you will know that asbestos causes mesothelioma and bronchogenic carcinoma. There are some other things it causes as well. Most importantly, it causes interstitial fibrosis, so people with asbestosis have stiff lungs that can no longer expand. It can cause pleural effusions and also causes localized fibrous pleural plaques, which can be seen on X-ray and give a clue that the patient's been exposed to asbestos. A further class of interstitial lung diseases is the granulomatous disease. Granulomas are a type 4 immune reaction, and in interstitial lung diseases they can be seen in sarcoidosis and hypersensitivity pneumonitis. Let's think about granulomatous inflammation for a moment. The predominant cell type is the activated macrophage. On the picture to the right, they're labelled E, the epithelioid cell. When these clump together, they form the giant cells that we often see in granulomas. It's a type 4 hypersensitivity reaction. In the picture, you can see centrally a giant cell, the epithelioid macrophages around the outside, and the little blue dots of the lymphocytes, the mononuclear inflammatory cells. We don't know what causes sarcoidosis. It's of unknown etiology. It's a systemic disease, so while it often shows up in the lungs with cough, It can affect the skin, the conjunctiva, just about anywhere in the body. We know it affects women more than men, and some people have suggested it might have an infectious etiology. If sarcoidosis is suspected, a chest x-ray might give a clue. Can you see on the right here the enlarged hilar lymph nodes in this patient with sarcoidosis? In the picture below, we can see white areas in the lung. These are fibrotic nodules. If we look down the microscope at sarcoid granulomas, we'll notice they're different to TB granulomas because they don't have caseous necrosis in the middle. They're just small round balls of epithelioid and giant cells. The slide at the right shows this. You can see the very round balls of the sarcoid granulomas. Because pathologists don't get out much, we call these naked granulomas. We think this is pretty clever, but what it means is that there's no lymphocytes around them like you see in the TB granulomas. They're found around the blood vessels and the lymphatics and the bronchi in the lung, which gives a characteristic fibrotic pattern which can be seen on X-ray. They're also often seen in the lymph nodes that drain the lung. Hypersensitivity pneumonitis has got many other names. It's also called extrinsic allergic alveolitis and hypersensitivity pneumonia. You may know it as things like pigeon fancier's lung. That's because it's an overactive immune response to inhaled, often organic antigens, like animal proteins from the pigeons, or bacterial spores in hot tub lung, or fungi or bacterial products. Sometimes hypersensitivity pneumonitis can present acutely, where people have fever, cough and white cells about 4 to 6 hours after exposure, but most often we see patients with a prolonged exposure and progressive respiratory failure, which can be reversed after the antigen is removed. Like many interstitial lung diseases, the X-ray appearance in hypersensitivity pneumonitis is relatively non-specific. There's bilateral diffuse and nodular infiltrates, which is seen on the CT scan to the right. Down the microscope, we see granulomas again. Can you see those giant cells surrounded by epithelioid cells? Notice how much extra lymphocytes are around and how thick those alveolar spaces are becoming. Finally, there's a group of fibrosing diseases that can cause the lungs to become stiff. The first two, usual interstitial pneumonia and non-specific interstitial pneumonia, are idiopathic. We don't know why they occur. The one I'm going to concentrate on is organising pneumonia. You'll see this most often. So organising pneumonia is a pattern of change. We've already seen it, for example, after pneumonia that doesn't resolve. Fibrous balls form in the alveolar spaces. So this can occur after multiple types of lung injuries. Infection, as we've just seen in pneumonia, but also drugs and toxins and collagen vascular diseases can cause these bundles of fibrosis to form in the alveolar spaces. The end pathway of all interstitial lung diseases is the same. It's called honeycomb lung. Not the honeycomb that bees make, but the kind of honeycomb that we would call hokey pokey, or the stuff seen in crunchy bars, with numerous quite large holes distinctly outlined by alveolar walls, but thickened alveolar walls, walls which have become fused together. So the fibrous scarring in honeycomb lung distorts the normal architecture. You often see on the surface it's all bumpy as the fibrosis pulls bits of the lung in. But the key feature is looking really closely at the cut surface, where you can see the enlarged air spaces surrounded by the thick fibrous walls. The loss of the small fine air spaces and the delicate alveolar walls means that oxygen exchange is severely impaired in honeycomb lung. brings us